I think it's recording now. Let's double check. Your screen sharing. I'm just trying to make sure it's recording. Okay, it is recording. Excellent. Okay. All right, everybody, we're going to talk about primary biliary cholangitis. We're going to talk about management of this liver disease, other complications, and dig pretty deep. The recording date is September 21st, 2020, and we're at La Maestra, but this will be posted on my website. Thank you so much. My only disclosures are working for Intercept. You can see robertgish.com for a posting of the slides. First off, we want to talk about patients and resources. There are a number of different applications, websites, where you have resources, calculators, and can actually talk about your current disease state, and how you're doing, how a provider might look at a patient's condition, including lay interpretation of AASLD and EASL guidelines. We'll talk about some introductory comments, self-care, patient-provider partnership, epidemiology, natural history, diagnosis, symptoms, treatment, and treatment of PBC as an extrahepatic disease. I'll be moving fairly quickly, but you can stop the recording at any time, pause, take a look at the slides, or download the slides separately. Important to know the difference between liver tests, liver enzymes, and liver function tests. AST, ALT, importantly, alkaline phosphatase are not liver function tests. These are liver enzymes. Bilirubin, specifically direct bilirubin, is the best liver function test. We also look at albumin and INR, a coagulation test. Ammonia is a very poor liver function test. We don't routinely test that even with people with cirrhosis or liver failure, only for special settings. We're now going to talk about the definition of PBC, formerly known as primary biliary cirrhosis, now known as primary biliary cholangitis. You have 2 of 3 of the following to be required to make a diagnosis of PBC: an elevated alkaline phosphatase, plus an AMA, or a positive antimitochondrial antibody, and a compatible liver biopsy. We're really thinking there's a new normal or new healthy for alkaline phosphatase of 85. That's going to be published in 2020 in the British Medical Journal Gastro, BMJ Gastro. I would refer you to that manuscript to look at a new target for a healthy alkaline phosphatase. PBC is a chronic progressive autoimmune disease with genetics and environmental triggers in the background, an immune response, and sequential small bile duct damage. This is the interlobular or septal bile ducts, and will lead to cirrhosis in the great majority, over 90% of patients without treatment. There's a PBC phenotype, usually over 45 years of age, female to male ratio 9:1, AMA positive in 95%. It's about 5% who may need a liver biopsy. Disease-specific anti-nuclear antibody is found in 30 to 50% of patients and can be ordered separately. Smooth muscle also may be present as an antibody. IgM is typically elevated. MRCP is not recommended for the workup of PBC, but it might be performed. It will be normal. The liver histology is a lymphocytic infiltrate, granulomatous bile duct destruction, an inflammatory duct lesion. If you see interface hepatitis, you have to consider the ability to diagnose an overlap syndrome. Inflammatory bowel disease is not a typical association, as it is in primary sclerosing cholangitis. The natural history of PBC, it says asymptomatic. Well, most of these patients actually have symptoms. They just don't have symptoms of end-stage liver disease. As we mentioned, over 90% of patients with PBC untreated will progress to cirrhosis, compensated and then decompensated disease. This may take 10 to 30 years. Typical average is probably 15 to 20 years from diagnosis. A lot of this has to do with the diagnosis being made early. Diagnostic considerations I'd like to highlight here along the left side, this issue of an overlap syndrome, usually liver enzymes, AST and ALT, are over 100. You may also look for IgG4 related disease. Look on the right side here, and you're going to be talking about other differential for this cholestatic liver biochemistry pattern, which means alkaline phosphatase is much higher, significantly higher than AST and ALT. Always do a workup for fatty liver in these patients. A FibroScan is very useful for determining fat and fibrosis. There's an algorithm here for the diagnosis of PBC. We've discussed most of the items on here, but it's important to emphasize the need for a full abdominal ultrasound with Doppler, measuring spleen size, portal vein diameter. Alkaline phosphatase is useful, but you should always get a GGT. The alkaline phosphatase is elevated and the GGT is normal. You need to be thinking about other causes of an elevated alkaline phosphatase, such as hyperparathyroidism. The impact of PBC we've highlighted. Almost all patients progress to end-stage liver disease without treatment. There's an impact on quality of life with a variety of different symptoms. Itching, dry eyes, dry mouth are quite typical. Insomnia, depression, cognitive dysfunction, recently highlighted in a publication this year, indicating these people just don't think very well. And the fatigue is probably a central issue that we'll talk about a little bit later. This is a complicated slide, and I'm not going to go through every component, but this is worthwhile keeping separately, printing out, keeping in your mind about stratifying risk, determining who needs treatment, which is basically everybody. You're going to restage, resurvey patients regularly. You're going to be managing their symptoms, their quality of life actively. I also recommend an upper endoscopy when people are stage 3. Stage 3 with PBC. Liver cancer surveillance is needed when people are at stage 4. Treatment options for PBC, there's been many failures that are listed along the left side, unsuccessful, questionable. I'm going to say those are not being used in my practice. Useful, ursodeoxycholic acid, first line, OCA, second line, bezafibrate, third line, fenofibrate, fourth line, really for special patients. There's 11 randomized trials for ursodeoxycholic acid, ursodiol. They've looked at different doses, different endpoints, different durations. Urso improves bilirubin, alkaline phosphatase, GGT, liver enzymes, improves liver transplant and overall survival, improves cholesterol and IgM, delays the development of esophageal varices, and delays histologic progression. This is the odds ratio for death or transplant using URSO. 4 of the studies overlap 1. As you can see, 3 studies and a combination of these combined analyses are to the left of the line, showing improvement, decreased death or transplant. Many of these studies took 5 to 10 years to accumulate enough patients and time to show a benefit of URSO, but URSO does work, but clearly we need additional therapies. Here's the natural history of PBC. Non-cirrhotic patients can do well over 6 years, but cirrhotic patients do poorly with a median follow-up in this study over 4 years. So once somebody has cirrhosis, they'll need close monitoring every 6 months, if not more frequently, managing portal hypertension, varices, and again, continued aggressive management, medical management. Elastography is quite useful. If the stiffness is greater than 9.6, much worse follow-up survival at 5 years. Less than 9.6 patients do well during that 6-month follow-up. You can also use the APRI score, APRI score. Here is a cutoff of 0.54 for a worse prognosis. So, URSO improves liver disease, liver tests, liver function, survival, decreased need for liver transplant. We really want to have all of our PBC patients have an alkaline phosphatase in the normal range. So I'll be talking about stepwise introduction of URSO. If you don't get to normal, you add OCA. If OCA doesn't get you to normal, you add bezafibrate. That's the three-step approach. Of course, I'll be managing things like no alcohol, having patients lose weight if they have fatty liver, and we'll be managing pruritus, fatigue, other problems separately. Here's UDCA associated with a number of treatment benefits. This is PBC. You can see this is placebo. Switch to URSO in this study. It's important to start URSO. We don't need to have any further placebo-controlled studies. The benefits in these studies are along the left side with the appropriate references. Inadequate response, there's been many different terms, scoring systems, researchers who've looked at endpoints. The treatment failure or is along the right side. I'd like to simplify this for everybody. We want alkaline phosphatase normal. We want bilirubin normal. A normal and healthy total bilirubin is 0.7 or less, and a normal direct bilirubin, healthy direct bilirubin, is 0.4 or less. There are side effects of URSO treatment, including abdominal discomfort, abdominal pain, hair loss in about 1%, diarrhea, nausea, 1 or 2%, worsening of itching in a few percent, rash also in some patients. I've heard about weight gain, although I've never seen weight gain in my practice from URSO, but maybe the patients feel better and they eat more. The treatment, of course, is to slow disease progression. This is a slide from the EASL clinical practice guidelines showing the evidence grade and recommendation grade. These are high quality of evidence, and the recommendations have a high grade as well. What about obeticholic acid? This was approved by the FDA a number of years ago. This is an FXR agonist. It acts at many levels in the liver on inflammation and fibrosis. I'll give you some brief information here about the use of this as second-line therapy in people who've had an incomplete response or are intolerant of URSO. Here is an improvement in alkaline phosphatase over 12 months after starting OCA compared to placebo in the light tan line at the top. And there are two different dosings that were done. Some patients went directly to 10 milligrams a day. Other patients went from 5 to 10 milligrams a day. Marked improvement in alkaline phosphatase. Yes, these patients are going to do better. And there's a lot of modeling studies that have come out since then that would show a much lower rate of death and transplant, even though the alkaline phosphatase is not normal. And of course, we want to make the next step. If the patients aren't reaching a normal alkaline phosphatase, it would be time to add a third medication. Reductions in bilirubin. Most patients had a normal bilirubin, but even in the normal range, the bilirubin improved. This is really telling us that 1.1 or 1.2 for a bilirubin is not the ideal number. We'd like the total bilirubin to be less than 0.7 milligrams per deciliter. Liver biopsies. This is a small study, but in a subgroup of patients, fibrosis improved. And this was correlated with improvement in liver enzymes, specifically alkaline phosphatase. So we make the enzymes better, and in a subset of patients, we have data that we're making the liver better, histology better. Here's mean changes in alkaline phosphatase and total bilirubin. Instead of 1 year, we now have data going out to 5 years published here. And in fact, there's data going out to 7 years. So once people are on OCA, they don't have breakthroughs. They don't have slow rises in alkaline phosphatase or bilirubin. So if there is a response, there's a long-term benefit of the response. I'm going to go very quickly through the next slides. Elafibranor is another medication with what are called PPAR alpha delta characteristics. And this also looked like there was some improvement in alkaline phosphatase. We're going to need more information on histology. This has a favorable efficacy and safety profiles. This has to do with alkaline phosphatase improvement, GGT improvement, improvement in different lipids, cholesterol, triglycerides, improvement in inflammatory markers. This may be a medicine we can use in the future. It's in research. Bezafibrate, I mentioned before. This has an improvement on cholestatic patterns here. And the study that was performed was to explore about OCA plus bezafibrate in terms of normalizing alkaline phosphatase and bilirubin level. There were 16 patients in the POISE study, and most of them were on URSO for 4 to 5 years. And OCA was terminated in 3 patients, 2 due to pruritus. Bezafibrate was added to this double combination in 11 patients. Endpoint was normalization of alkaline phosphatase and bilirubin. So this is another higher bar. It's not just an improvement of 15% or less than 1.67 times upper limits of normal. In this study, we had OCA plus bezafibrate, had a strong positive effect on bezafibrate, improving pruritus as well as a marked reduction in alkaline phosphatase. The data and information is on this slide for you to look at in more detail. This was compelling and a reason that I'm advising bezafibrate as a third-line drug to be added, and eventually in some patients will be on triple therapy. They can't tolerate URSO or OCA, they may be on double therapy as well. This is bezafibrate plus URSO versus URSO alone. 67% of patients had a normalization in alkaline phosphatase. This is very impressive information. This is add-on therapy in PBC with a little bit more information about the study design. The rate of incomplete response is the opposite of 70%, was 30%. And those patients who didn't respond as well had substantial pruritus, had portal hypertension, had very high liver stiffness, high bilirubin, high liver enzymes, including AST. Information here about add-on moving to the left of the line basically predicts lower 15-year mortality and lower need for liver transplant. So bezafibrate, from a modeling perspective, is going to have clinical benefit as well. A little bit more about add-on therapy here, using a blood test called fibrometer or a blood test plus stiffness, VCTE. And in this study as well, we're talking about an improvement. Here it's going to be to the right of the line. You're going to have what would look like a worsening, and to the left of the line, improvement. So across all 3 of the different tools that were measured here, that looked like this combination therapy was going to benefit patients. Statins, fibrates, PPAR, there's a whole review in Gastroenterology and Hepatology 2020 talking about a variety of different studies and benefits of these medications. So I'd have you review these and look at endpoints, study design. But look at this, alkaline phosphatase improving in every single study. So we have some options out there for our patients currently and in the near term. I do want to highlight that fenofibrate is available in the United States, but has a black box warning about using it in patients with chronic liver disease. I think this is an over-exaggeration, but there are patients who can have renal effects, kidney effects, and liver effects from fenofibrate. So if it's used off-label, close monitoring is advised. Another research drug called GKT831, also in people who did not have a response to ursodeoxycholic acid. This is an inhibitor of something called NOX1/4. Again, this is a research study that also showed a dose response, time-dependent reduction in alkaline phosphatase and GGT. So this may be used at some time in the future as well. Ursodeoxycholic acid I use after liver transplant in all of my PBC patients. And this is because this data shows decreased disease recurrence and prolonged graft survival. So if I have a patient going to transplant PBC, they all go on URSO long-term. This just shows no preventative UDCA in red, cumulative events up to 60%, and patients on UDCA, cumulative events cut in half at 30%. So recurrence of PBC can be as high as 50% by biopsy, And in patients on URSO, it could be as low as 20%. This is a proteome. This is assessing proteins in the blood of people, PBC, who are untreated and people on URSO. I'll just describe that the proteome is largely unchanged in these two individuals, but UDCA modified the PBC proteome, showing significant pathway clustering, showing it looks like ursodeoxycholic acid is changing the protein, different protein signaling production in the liver and systemically. Finally, the analysis is the first time they looked at the PBC proteome and then looked at cytokine and cytokine receptor interaction, something called TLR signaling, tumor necrosis factor signaling. URSO non-response and alkaline phosphatase are candidates for starting second-line therapy, probably because they're not having an effect, substantial effect on these inflammatory pathways. What about itching? A lot of things we can do for itching. I'm going to move through this section quickly. Please come back and review this information. There's a lot of pathogenetic ideas that people have, or pathogenic ideas that people have. It may actually be genetic, I guess, too. And many different diseases that are cholestatic cause itching. It's not just PBC. You can see it in PSC, drugs, hormones, alcoholic disease, different genetic types of cholestasis. How do we manage this? Well, first off, make sure there's no stones, make sure you have the correct diagnosis, make sure someone doesn't have kidney failure and is on dialysis. Itching can occur in pregnancy as well. Autotaxin is one of the proposed signaling, and we're trying to develop medicines that might target this pathway. Autotaxin develops something called lysophosphatidic acid, which may be a signaling mechanism in itching. So again, something that might bind or change lysophosphatidic acid may decrease itching. I think this is how primrose oil works. Primrose is first line for me in this itching management. A little bit more on the structure of lysophosphatidic acid. This stimulates cell proliferation. Some people think it might even be oncogenic, but I think it's the cause of itching in a subset of patients with cholestatic diseases. Not everybody. So ursodiol actually improves itching in many patients. I don't like cholestyramine because a lot of patients dislike the sand-like flavor. Naltrexone's a little bit harder to manage. There's also a black box on naltrexone about using it in liver patients, which I think is exaggerated, overblown, since I think this is quite safe to use. Rifampin, though, can cause liver injury. And these are not my first line medicines that I use, but I'm just putting them here because this is what's in the guidelines. I have a different approach, not in the guidelines, such as using sertraline. This is really good for people to get more energy and combat itching. There's some really good data that sertraline and these SSRI antidepressants work well. A little bit more information here on managing pruritus. You can look at the different graphs and the symptom scores. This is my pruritus sheet that you can find at my website. You can print this off. You can see my top 3 or 4 along the left side. Primrose oil, over the counter. Atarax, very inexpensive prescription. Start with low dose because it can be sedating, as can Periactin. Benadryl, bedtime, good for itching. But I'm really going to move quickly to sertraline in my patients, or doxepin, also for itching. I'm going to use naloxone or naltrexone as second or third line or fourth line agents. There's many, many other options here. I've had Zyrtec work on some patients. I've had peppermint oil work. I've had dandelion root work. A lot of patients are not adverse to trying some of these homeopathic options. Fatigue, we don't know the cause. There's some effect on prognosis, but other studies have said not an association with outcomes. URSO doesn't help. Prozac can help, and some of the other SSRIs are mood activating. Modafinil is quite useful, but quite expensive. What else can we think about in these patients? Look at the bottom one on this slide, caffeine. So I recommend 2 to 3 cups of coffee before 10 a.m. Could also be tea. And remember, these coffee and tea, it's not just the caffeine, but the coffee and tea are anti-inflammatory in the liver. A little bit more on fatigue. This is one that said more fatigue had a worse survival, but I can show you other studies that showed fatigue did not have an effect on survival or was not associated with a change in survival. A little bit more on this from Dr. Jones. A little bit more on fatigue, low fatigue, low fatigue. A little bit more on this. Modafinil. This is something called a sleepiness scale. And when the numbers go down, that means better, you're less sleepy. Modafinil, I believe, works. Although some of the literature you'll read out there said doesn't work. I think it's been quite helpful in managing my patients. Special settings, pregnancy. Well, it's nice that URSO can be continued in pregnancy. It's called pregnancy category B or A. Pruritus management and rifampicin has been used by experts during the 3rd trimester if the itching is really terrible. If a woman has PBC and already has itching, then she gets pregnant, the itching can get much, much worse and can be very life disrupting. Other symptoms are here. This is just grade of evidence, grade of recommendation. Very important that all your PBC patients have an eye exam every year for Sicca syndrome, tear production, really good dental care. Dental exam, dental cleaning 3 times a year is my recommendation. A little bit more about osteoporosis. DEXA scans due every year. You supplement vitamin D up to 40 to 50, calcium every day, and then you can use bisphosphonates or other medications that can help stabilize or improve bone health. If the patient has an elevated direct or total bilirubin, you want to check not just vitamin A and vitamin D levels, but you may want to supplement vitamin E in these patients. If the coagulation test is abnormal, you might want to give vitamin K sub-Q. All patients need to be assessed for celiac sprue or gluten sensitivity, since sprue can be found in 7 to 15% of PBC patients. PBC patients can have very, very high cholesterols. I've seen between 1,000 and 1,500 in some patients. They typically require plasmapheresis and urgent liver transplant to bring that under control. But lower levels of cholesterol need to be treated depending on the patient's cardiovascular risk or ASCVD score. A little bit more on hyperlipidemia. What's interesting is that UDCA and OCA both have effects on LDL. So UDCA lowers LDL, OCA increases LDL, and actually decreases HDL slightly. So it's nice to monitor not just cholesterol, but subgroups. A little bit more in management. I mentioned doing endoscopy at stage 3 disease, doing banding according to guidelines. Once a patient's documented to have cirrhosis, you'll be doing liver cancer surveillance. Liver transplantation is indicated when the MELD score, at least listing, is over 15. Most patients are getting liver transplant when the MELD score is 25 to 35. Clinical care delivery, this is really structured to have a multidisciplinary team manage the different aspects of this care. Being managed in a liver clinic ongoing regularly is highly advised in all PBC patients. This is a clinical care standard that are here, and they are listed along the left side. I think we've talked about everything that's here, but this just says this is a checklist you need to go through and interventions that need to take place. Other management steps, I think we mentioned thyroid, but check a TSH at least once a year. We mentioned DEXA scan, we mentioned fat-soluble vitamin E, we talked about endoscopy, we talked about liver cancer surveillance. The other treatment algorithm here, about starting with URSO, itching, adding OCA, thinking about fenofibrate or bezafibrate. It's a nice, smooth, simple structure. Finally, we're going to just wrap up with a couple of interesting slides. This just goes to show you how complicated PBC is with interactions between B cells, dendritic cells, antibodies, special types of antibodies, apoptosis that's occurring, bile acid interactions, what's called biliary fibrosis from different types of cholangiocytes with different types of signaling that are present, NK cells, T helper cells, what are called mate cells, and Th1/7 cells. So very, very complicated, but the research in PBC over the last 2 decades has been extremely exciting. Finally, long-term management, liver tests every 3 to 6 months, URSO first, OCA second, bezafibrate third, fenofibrate fourth, thyroid, bone, other autoimmune conditions, nutrient, vitamin assessment, endoscopy, liver cancer surveillance. PBC is mostly commonly diagnosed in middle-aged women. Take a really good history, look for other causes of liver disease, overlapping liver disease, monitor alkaline phosphatase and GGT together, avoid liver biopsy in most patients, manage with URSO first, OCA second. If people can't tolerate URSO, OCA becomes first-line therapy in those individuals, or GES therapy 1.1, and again, evaluate for all common causes of liver disease. Many people, many companies have been involved in this space, and I'd like to thank all individuals and the team here at La Maestra for helping me. Thank you.